We are live.
A very good evening, everyone. Welcome to the iFocus online lecture 426 of the Cataract module. Today, the topic for the class is Secondary Intraocular Lens Implantation and Stabilization by Dr. Gauri ma'am. I would like to introduce the moderator for the session, Dr. Prafulla Kumar sir. Sir has done his MD Senior Residency in Cornea, Cataract and Refractive at RPC AIMS, New Delhi. Sir is currently an additional professor at RPC Center, AIMS, New Delhi. Sir is also the current secretary for DOS. Sir is the chief editor of Ophthalmology Clinics 2 and postgraduate ophthalmology book series. Sir has published over 395 Google Scholar and 156 PubMed index papers, more than 50 chapters in national and international books. Sir has also received the Best Surgical Technique Award from RANSCO, Young Achiever Award at ISCKRS, Ajit Babu Maji Award, and the awards for Best Paper in various conferences. Sir has been the principal investigator in 2 ICMR trials, co-PI in 18 trials, including 2 multicentric international trials. Sir has been teaching co-in charge at RPC Center since 2016. Welcome, sir.
Thank you, Garvita.
I would now like to introduce the chairperson for the session, Dr. Subodh Kumar Sinha, sir. Sir has done his MBBS from DMCH Darbhanga, MS from IMS BHU, and MSc in Community Eye Health from the prestigious International Centre of Eye Health, London School of Hygiene and Tropical Medicine. Sir finished his fellowship from Arvind Eye Hospital. Previously worked as a consultant at Venu Eye Institute, New Delhi. Currently, Sir is a senior consultant at Center for Sight, Cataract, Glaucoma and Refractive. Sir is also the conducting teaching and training programs at ECC, SICS and FACO for DNBs and fellows. Sir has worked with NPCB and State Blindness Control Societies to establish eye care services in Arunachal Pradesh and Bihar. Sir has also done facility survey in eye care services at North Korea and has helped with development of guidelines for cataract management in Sight Savers International. Finally, I would like to introduce the speaker, Dr. Gauri ma'am. She's finished her DNB from Aditya Jyot Eye Hospital, Mumbai. Also, fellowship in Vitro-Retina Surgery, Arvind Eye Hospital, Madurai. Then, ma'am did her FICO degree in Vitro-Retina in 2020. Previously, ma'am has worked at ASG Eye Hospital. Currently, ma'am is an associate consultant at Center for Sight, New Delhi. Ma'am is also the fellowship in charge for the Department of Vitro-Retina Services at CFS New Delhi. Ma'am has published various papers in national and international journals, also presented in various national and international conferences. Welcome, ma'am.
Good evening, everyone.
Good evening, Dr. Khare.
Good evening, sir.
Just before she starts her talk, for PG students, postgraduate students, secondary eye implantation is a very important topic. Not only because you people do ECC, SICS, FICO and land up in complication. From exam point of view also, you may get a patients of aphakia and it may be given to you as a short case. Also, secondary eye implantation and aphakia, all this can come as a short note. So please pay attention to the class and we can go ahead with the class, Dr. Gauri.
Yes, sir. Is my screen visible?
Yes, ma'am.
Okay. All right. So, secondary IOL implantation and stabilization is the topic for the day. So, when is secondary IOL? One second. Yeah. When is secondary IOL needed? So, it is needed in cases of aphakia after a complicated cataract surgery or in trauma patients with crystalline lens or IOL dislocation or loss, ectopia lentis cases, or IOL exchange, which can be done for various reasons like incorrect power or IOL subluxation, opacification, photopsias, dissatisfied patient, or IOL-induced endothelial decompensation, which is pseudophakic bullous keratopathy, or IOL removal in cases of chronic endophthalmitis, which is lens-induced. So in aphakia, where the PC is absent, we have to see whether the anterior capsular support is present or not. If it is present, we implant the IOL in the ciliary sulcus. But if it is absent, we have to look for alternate methods like AC IOL, iris law lens, which could be anterior or posterior, or a scleral fixated IOL. Coming to the implantation in the ciliary sulcus, usually a three-piece IOL is implanted with or without optic capture. Doing an optic capture actually provides more stability and more centration. It also helps in preventing the vitreous prolapse anterior to the IOL, in addition to causing less myopic shift in comparison to a sulcus fixated alone. So the various techniques which have been described for optic capture are optic capture through CCC with haptics in the sulcus, haptic in the sulcus with the optic capture through the posterior axis, haptic in the bag with optic capture through the posterior axis, haptic in the bag with optic capture through the CCC. In case of very young patients, that is children especially, or uncooperative patients, we can do a bicapsular capture where the haptics can be placed in the ciliary sulcus and the optic could be through both the CCC and the posterior axis. So there's a video over here which shows the implantation in the sulcus. So it is a femtosecond cataract surgery. So a femtosecond rhexis has been made. Once the capsule is removed, side port is made, then hydrodissection is done, followed by phacoemulsification. Once we are through the phacoemulsification part, IA was started. During the IA, PCR was noted. After this, a vitrector was taken. The remaining IA was completed and a thorough vitrectomy was done. A thorough anterior vitrectomy was done. The section was enlarged and a three-piece IOL was then injected. The leading haptic is targeted towards the ciliary sulcus. Then with the help of a manipulator or a Sinski or a dialer, we can take the trailing haptic also in the ciliary sulcus and the lens is stabilized. The wound was then secured with the help of 10-0 nylon. Coming to the ACIOL. ACIOL has gone through a series of modifications. It was first So currently, it first came as it first came in the form of Mark and then Azar. Currently, what we are using is Kelman Multiflex, and it has an optic, and it has haptics followed by the foot plates. The foot plates of the IOL are the ones which would get anchored in the angle at the level of the scleral spur. The ACIOL has to be taken out from the packing and has to be implanted in the same fashion because it has a vault on one side. Now, the vault has to be placed superiorly because it gives a little height and also allows the aqueous to flow out. However, creating a PI is mandatory. It's a PMMA rigid and non-foldable material. It is anteriorly vaulted. it is very, along with the power of the lens, what is very important here is to size the length of the IOL. So a horizontal wide to wide diameter is taken, which is usually there on the IOL master. And then you add a millimeter to it. That is the desired size of the length of the AC IOL that is implanted. Now, we cannot choose our main phacoemulsification wound, the main port, which is usually temporal for most of the surgeons. Because the size of the IOL is large, we have to enlarge the wound. So usually a superior scleral tunnel or an ECCE wound would be helpful in this. So in the video that we are seeing here, there is an aphakia and then the tricot was injected, after which peritomy was done. And a scleral tunnel was made. Following this, vitrectomy was done. And then the lens was injected. 1 second. The lens is injected, then with the help of manipulator, it is made horizontal. IA is done at the same time. And then a peripheral iridectomy was made. Iris is pushed back. And then the wound is secured with the help of 10-0 nylon sutures. And the conjunctival peritomy is closed by 7-0 vicryl. The complications associated with ACI will include pseudophakic bullous keratopathy, which is more commonly seen if the IOL is smaller in size due to repeated dislocation of the lens. Glaucoma is more common with IOLs which are larger in size. Also, if a PI is not made, glaucoma is more common. Peripheral anterior synechiae are also seen more commonly with a larger sized IOL. A uveal glaucoma hyphema syndrome, and due to repeated inflammation, then cystoid macular edema. Next, coming to the iris claw or iris fixated lenses, they were first described by Kollerstadt as Kollerstadt by Epstein in 1954. In 1960, Koller implanted the first iris fixated lens after an ICCE. In 1971, Wurst came with the iris claw lens, and its modification over a period of time evolved into artisan lenses, which we are using currently. For a successful implantation, a good vitrectomy should be done in the anterior chamber, at least 270 degrees of iris tissue with a pupil size of less than 6 millimeters should be present. If the pupil is more than that, say because of traumatic mydriasis, then a pupilloplasty must be performed. An anterior chamber depth of 3 millimeter or more is needed. So here is a video. It can be the iris fixated IOL can be both anterior or retropupillary in terms of fixation. So this is a video showing retropupillary fixation of iris claw lenses. So 2 points 180-degree apart are marked. A side port is made at both the ends, followed by pilocarpine injection and tricot to stain the vitreous. After this, conjunctival peritomy is done, and then a scleral tunnel is made, followed by vitrectomy. Once the vitrectomy is done, we are planning an anterior fixation. Then it is very important that we make a PI which is not covered by the lens. This particular video shows a retropupillary fixation. Now we are making the corneal entry and we have put the lens inside. with the help of a manipulator or a Sinski, you're making the lens horizontal, or it could be any other desired position if there is an iris defect. And there is a iris claw holding forceps, and it has two markings which usually demarcate the point of inclination. Then one side with the help of the forceps, individually, each side will be put retropupillary, and with the help of a Sinski or a cannula, or some people even use manipulator to enclave the haptics in the iris. Once you see a dimple on the side, it shows that the inclination is done. At the end, it is important to clear the OVD from the chamber, otherwise it results in high IOP post-surgery. The complications include endothelial loss, which has been said mainly due to the mechanical injury due to the surgical procedure. Also, a shallow AC or a shorter distance from the IOL edge to the endothelium leads to a higher endothelial loss. IOP is more with an anterior fixated than a posterior fixated one. Wound leak due to a large section and persistent ovalization of the pupil. There could be a dislocation of the lens if the inclination fails. CME due to chronic iritis. There can be hyphemia or a UGH syndrome, retinal detachment. Endophthalmitis can happen after any ophthalmic surgery, intraocular surgery. Next, coming to the scleral fixated lenses. So first came the sutured lenses, then came up sutured SFIOL, then came the sutureless SFIOL. So the sutured SFIOL needed 10-0 polypropylene or 9-0 polypropylene or Gore-Tex suture, while the sutureless is what is more common in today's date, which is Gabers or Yamane's technique or fibrin glue assisted SFIOL. So first, what we are going to see is the Gabers technique. So here in this particular video, we have made a temporal, it is a case of aphakia where nasal and temporal peritomy is made. And then 2 points are marked on each side at 1.5 millimeter. Then a scleral tunnel is made with the help of MVR. And 3 pars plana ports are made at 3 millimeters. Infusion is placed. Anterior vitrectomy is done, followed by core vitrectomy. And then a PVD induction. PVD induction is not mandatory. However, inducing a PVD during the surgery minimizes the risk of post-op retinal detachment. After this, a corneal incision is made and sclerotomy is made with the help of MVR or a 24-gauge needle. Then the IOL holding forceps, SFIOL forceps, is taken through the sclerotomy and the lens is injected. The leading haptic, the tip of the leading haptic is caught by the SFIOL forceps and is brought out. Same is done on the opposite side. Then with the help of the same SFIOL forceps or McPherson forceps, the tip is grasped and the haptics are inserted into the tunnel. In this case, there is a traumatic mydriasis. So we are doing 1-pass 4-throw technique for pupilloplasty. And we have treated the at the end, the conjunctiva is closed with 7-0 Vicryl. However, a glue can be used to close the conjunctiva. Next, coming to the Yamane's technique. Now, the difference here is that in Yamane's technique, there is no conjunctival peritomy. Here, a direct scleral entry is made through the conjunctiva. So we will see in this video just the important points. So 2 points 180-degree apart. So 2 points 180-degree apart are made. An AC maintainer is put. Now, a 3-piece lens is injected and a 26-gauge needle is inserted through the sclerotomy. With the help of SFIL forceps, the leading haptic is threaded into the 26-gauge needle and is brought out. Exteriorization of haptic is done. Looks a bit technically challenging. Same step is done on the opposite side. Once the haptics are exteriorized on both the sides, with the help of a ballpoint cautery or any cautery that you have with you, what you can do is cauterize the tip of the haptic. So what you'll see here is a bulb tipped end. Now this is larger than the size of the sclerotomy that we have made. Following this, the haptics are pushed back into the vitreous cavity, but it will not fully slip as the tip is blunt and rounded. Over a period of time, over next 1 to 2 months, conjunctivalization happens over the tip of the haptic. Until then, there's always a risk of end-off happening through the tip, through the exposed tip. Now, the next technique that I'm going to show you here is XNet technique by Dr. Prabhu Bhaskaran. So 2 points 180-degree apart are marked and conjunctival peritomy is done. Then with the help of MVR, the chariot tunnels are made at 1.5 millimeter from limbus on both the sides. After this, AC maintainer is inserted and a thorough anterior vitrectomy is done. After this, a scleral tunnel is made. I am from Bangalore, Karnataka. So the reason why I joined this now 26 gauge needle, which is bent at the hub, is inserted through the sclerotomy and is brought out from the scleral tunnel. After which the haptic of the 3-piece IOL is threaded into the needle. The needle is then brought out. The needle is then brought out. At the same time, the optic has to be pushed in. What we are seeing over here is a small silicon band which was inserted in the 26 gauge needle. Basically, it helps in preventing the haptic from slippage. However, it is completely optional. Similarly, 26 gauge needle is inserted from the opposite side and is exteriorized through the corneoscleral tunnel. And the haptic is threaded inside with the help of a MacPherson. Sorry. And the haptic is brought out. Both the haptics, then with the help of SFIL forceps or MacPherson, are then engaged in the scleral tunnels. The scleral tunnel is then secured with a 10-0 and the conjunctival peritomy is closed with a 7-0 vicryl. Next is Dr. Agarwal's technique of glued SFIOL. So here what is done is localized peritomy, nasal and temporal, okay, followed by diathermy of the sclera to prevent surface bleeding. After that, at 1.5 millimeter from the limbus, we'll mark a position where we are going to make the flap on both the sides. Then a partial thickness groove is created with the help of a Bart Parker knife, Bart Parker blade and knife. Now with the help of a crescent, a scleral pocket is made. And then we lift this scleral flap. AC maintainer is then brought in place. Now sclerotomy is made under the flap using MVR on both the sides. Corneal incision is then made and the IOL is injected. SFIL is inserted through the sclerotomy and is brought into the pupillary plane. The leading haptic, the tip of the leading haptic is caught in the forceps and it is then externalized. The trailing haptic is exteriorized with the help of handshake technique. Where the SFIL forceps is inserted, brought into the pupillary plane. With the help of MacPherson, the trailing haptic is brought close to the tip of the forceps and is caught by it and is brought out. And is now it will be externalized through the sclerotomy. Then with the help of the same SFIL forceps or McPherson, the haptic is tucked into the scleral pocket, stuck into the scleral tunnel. Main wound is closed with a 10-0 nylon. Once the haptics are tucked in, AC maintainer is removed. The port is the incision is hydrated. Now the scleral surface, after the hydration of the wound, the scleral surface is dried out. And once it is well dried, fibrin glue is placed and the flap is reposited back. Similar mechanism has to be done on the other side. After that, the glue can be placed on the underside of the conjunctiva and the peritomy can be closed with the help of glue. So these are the latest techniques. Now we are going to discuss about what used to happen in the past. So I'm showing you here a sutured SFIO. So it's a hypermature cataract. Two scleral grooves are made at almost 2 millimeters from limbus. After that, ICC is done and the cataract extraction is done with the bag. Then the main wound is secured with 10-0 nylon. Now, what we do here is that from one side, we push in a 26 or 26 gauge needle, and from the other side, we push in a 10-0 or a 9-0 nylon suture, which we thread inside the needle and is brought out from the other side. Now, this 9-0 nylon, it has needles on both the side. See, the other side is again through the scleral grooves that we have made on both the sides. A similar act is done where the needles pushed from one side and the needle with the suture is threaded inside that needle on the opposite side and is brought out. After this, with the help of Sinski, we bring out the sutures in the pupillary plane outside through the main port. And we cut both the sutures. So now the SFIL which is used has two eyelets. So here in the eyelets of the SFIL, we have to pass this suture and we have to tie a knot on each side. Secure the knot on both the sides. Following this, the IOL is then, with the help of forceps, the IOL is then inserted inside and the sutures are pulled out on both the sides. Insert the rest of the IOL here. And the sutures on both the sides, they are pulled out. After pulling out the sutures, have to tie once again to secure it in place, and the remaining suture is then cut. Conjunctiva is then closed. You can cut the remaining suture and conjunctiva is then closed with Vicryl. Always remember that you have to rotate the suture so that the knot is not exposed. Otherwise, it can erode the conjunctiva at a later date. Can lead to end off also. Next video is showing the Gore-Tex sutured SF IOL. So here the IOL is 4-point IOL. The IOL used is the 4-point IOL fixation IOL. So a conjunctival peritomy is done. And two points are marked on the sclera at 3 and 9 position. After this, 3 ports are placed and pars plana vitrectomy is done. Due to the pre-existing pathology in the retina, 360-degree laser was done. Two sclerotomies are made on both, one on the nasal, one on the temporal side. After this, a spiral tunnel is made and the pre-existing ACIOL is explanted. Now, Gore-Tex suture is passed through the eyelets in the haptics. So the same thread on the same side, the same thread would be passed. So one thread on each side. After this, you can take a max grip forceps, pass through the sclerotomy, and catch hold of the first suture of the leading haptic over here and bring it out. Going through the port, the other end of the suture is brought out. After this, the IOL is inserted inside with the help of a MacPherson. And then again, the suture of the leading haptic is taken out with the help of max grip forceps, and the suture in the trailing haptic is brought out through the port. After this, both the ports are removed. And the sutures are tied. Suture is then rotated to suture is then rotated to bury the knots on both the sides. The conjunctiva is, the wound is secured with the help of 10-0 nylon. Conjunctival peritomy is closed with 7-0 Vicryl. Now, what is very important in today's era, what we are using is a 3-piece IOL, whether foldable or non-foldable. So it is important to see the kind of haptic that this IOL has, whether it is a C-loop shaped or it's a modified J-loop shaped. So if it is a C-loop shaped, the haptic over a period of time has a higher tendency to extrude. So in such cases, the tunnel should be made, started at 1.5 millimeter from limbus, but it should be directed away from the limbus. However, if it is J-shaped loop, J-loop shaped, then the tunnel is directed towards the limbus. So whatever technique of secondary IOL we are doing, it is very important to take care of the vitreous, because if the vitreous is not managed, it will result in literally all the complications we can possibly think of. Then if you're talking specifically about SF IOL, so the centration of the IOL depends upon the haptic exit points. So we have to make sure that the exit points are, exit point is what is 180 degrees apart. IOL power calculation should be done keeping in mind that SFIOL will be posterior to the plane than the traditional IOLs. And then thorough posterior segment examination pre and post surgery should be done, because there can be breaks which should be taken care of during the surgery itself. The complications associated with SFIOL are retinal detachment, vitreous hemorrhage secondary to the uveal bleed, ocular hypotony, choroidal detachment, which would be seen usually immediately post-op, or haptic extrusion or subluxation or dislocation of the IOL. Endophthalmitis can be associated with any intraocular surgery. So now when we talk about secondary IOL, what is very important is the power of the lens that we are implanting. So it's very important to take care of the A constant. So ACIOL in its expected location has an A constant of 115.5. PCIOL in the sulcus has an A constant of 117.5. IOL will be labeled as 118.5. In the bag, it is 118.5. Although the difference in the sulcus and the bag, for the difference in power between the sulcus and the bag, rule of 9 should be followed. So if in the bag, the power is between 0 to 9, there is no change in the power for sulcus placement. If the power is between 9.5 to 18, reduce the power by 0.5 for sulcus. If it is between 18.5 to 27, reduce by 1. And if it is 27.5 or more, reduce by 1.5. Now, if the haptic is in sulcus and optic capture is through the capsular rhexis, use the in the bag power, because optic is still technically behind the anterior capsular rim. Now, if the haptic is sutured to the back of iris, usually these sutures are not very tight, they are loose. So we can use in the bag power. Haptic and optic both are in sulcus, then use the sulcus IOL power according to the rule of 9. So this chart is basically showing similar to what we have just spoken. Difference in the A constant power also between, difference in the A constant power, A constant shows the difference in the power of the IOL that is to be placed. One very important thing to be noted while planning the surgery is the specular microscopy. Because when we talk about ACIOL, when we talk about iris claw lenses, they all have a risk of pseudophakic bullous keratopathy. Also, aphakic patients themselves, they have a risk of bullous keratopathy. Some of them do come with the same. So it is important that we see what is the cell density and what is the status in terms of polymegatism and pleomorphism. and accordingly we have to counsel the patient. If the cell density is normal, that is between 1500 to 3000, it's fine. But if it is less, but still the cornea is clear, you have to tell the patient about the consequences, because there is a gradual, over a period of time, there is a drop in the endothelial cell count. If the patient has already come with a bullous keratopathy, then the patient has to be told about the possible probable need of a DSEC in future. So the take-home message here is that scleral fixated IOLs have revolutionized the way we deal with aphakia. Dealing with vitreous is the main aspect which has to be kept in mind before we, go ahead with any kind of IOL insertion. But finding your own personalized technique from a wide array of different techniques will give the best outcome. Thank you.
Thank you, ma'am. That was a lovely presentation.
Thank you, Garvita.
Ma'am, we have one question from the chat box. If we do not have SFIOL forceps, how to proceed in that case, ma'am?
So in those cases, you can actually, the gripping with the ILM forceps is not very great, honestly, because a lot of times you will lose the haptic. But yes, ILM forceps can be used because I've used it myself multiple times. Also in those cases, why not use XNet? Just go ahead with XNet technique. It's a very good technique. And whether you see, you do, even if you don't have a, you always have a 26 gauge needle. You can always make a scleral tunnel, exteriorize the needle through the tunnel, and then thread in the haptic with the help of a Macpherson. So all these things are always there in a cataract set. So that is easy. Other than that, ILM forceps, yes, you will lose it 1 or 2 times, the haptic tip, but then eventually you'll catch it.
Thank you, ma'am. Ma'am, I would like to invite the moderators and the chairpersons for their valuable input.
Thank you, Garvita and Dr. Gauri. It was a wonderful talk, and the best part was all the videos that you showed. It's often difficult to have all the techniques of SFIL videos, and you got all the videos of all the technique. For
Thank you.
for residents, I would like to highlight few points. Whenever you get a case or a short case or a short note of as a secondary IL, a few things that the examiner very fond of asking. So I'll just go through that. First is they will ask why secondary IL, why not to call a primary IL, because you have done a phacoemulsification and you could not put the IOL in the first setting, and you are trying to put an IOL in the second setting. That's why the name is secondary IOL. That is one. Second, most important, they would ask you when you are examining the patient or we are doing the workup, which are the important points that must be there in your history and examination, right? So the points that Gauri also highlighted, that you have to assess the best corrected visual acuity of the patient first, right? If a patient is there, first check out whether the patient is improving with either spectacles or contact lens FAK glasses. Okay, if you are able to get a BCB of 612, 618, then only go for surgery. The second important point in all FAK is IOP. IOP is a must because FAK glaucoma, which can be due to progressive past, that could be there. Third important point is corneal endothelial status. As Dr. Gauri showed you, specular examination is very critical. If you don't have a specular microscopy, at least do a specular reflection and check for corneal thickness. So any increase in corneal thickness is the earliest markers of your specular dysfunction, okay, endothelial dysfunction. So that is important. Cornea, IOP, BCVA, and retinal examination. All these aphakic patient, if somebody has left the patient aphakic, that suggests there must be some complication during surgery, some interaction with vitreous, some stretching of vitreous. So this patient may have multiple small holes or tears in the ora serrata area. So you need a dilated fundus examination, preferably after indentation in all patients of aphakia before going ahead with your IL implantation. So these are the questions that the examiner may ask you, which all things are important before putting an SFI. Then the techniques, Dr. Gauri rightly enumerated all the techniques. So that I am not going to discuss now. She has covered it quite well. But after that, follow-up is also very important in all these patients, because glaucoma and endothelial decomposition, these are the two common problem that can occur in this group of patients. And these are the questions that somebody may ask in viva voce, or otherwise I think she covered all the topics quite well. And congratulations, Dr. Gauri, for that.
Thank you
One
so
question:
much.
what is your preferred technique of SFI?
I personally do Sir Gaber and Chariot, but yes, I do incorporate a lot of other things. I'll tell you honestly. So if I have a very high myope where the haptics are actually falling short, the haptics are actually elongated, I'll do a Yamane at the tip. Basically, I'll do a cautery at the tip because I know that this lens has a very high chance of slippage. So I will usually do that cautery at the tip so that my lens doesn't slip off. Then if my cornea is not very good, sometimes if the cornea is not very good, then catching that haptic tip in that much of corneal edema, or if the corneal opacity is there, then I would go ahead with XNIT.
Okay. So
Yeah.
given a choice between ACIL and SFIL, what would be your preferred IL implantation technique?
I'm very comfortable with SFIs because I'm a vitreoretinal surgeon, so I'm very comfortable with it. But
So from exam point of view, suppose the examiner asks the PG, what is your preferred technique? What should be the
so,
answer?
I mean, preferred technique, if I am the operating surgeon, then definitely I'll go ahead with SFIL because the chances of pseudophakic bullous keratopathy are much less. Long-term results are much better. And at the same time, I'm taking care of vitreous very well. So the chances of retinal detachment reduce. Also, that I know that once I've put, even if this patient doesn't come back to me in long run, I know the patient is okay. And the day this patient will lose vision, it will be mostly because the IOL has either subluxated or has dropped. So something like glaucoma happening to this patient, until and unless the patient is previously a glaucoma patient, the risk of glaucoma or a bullous keratopathy happening in this patient are much less. So I would prefer SFIOL in today's date, any day.
Even most of the surgeons they prefer SFIL, but for students, in an examiner, if the examiner is very senior and he asks you this
Yeah.
question, whether you go for SFIL or HL, don't say that I'll prefer SFIL. Why? Because older people who are comfortable ACL, they still do ACL. And
True.
what the perfect answer for a resident would be, sir, as far as studies are concerned, in a normal eye where endothelium is fine, no glaucoma, both ACIL as well as SFIL, they perform well. If yes, normal means no glaucoma, endothelial count is normal, and iris anatomy is normal. Okay,
Yeah.
then both ACIL and SFIL do well. But whenever there is a risk of pus, glaucoma, or endothelium compromised, then the preferred technique is always SFIL because that doesn't hit your endothelium with the movement of the eyeball. So that is the preferred technique. So that is the answer from exam point of view. But most of the surgeons, including me, we have almost stopped putting SAL nowadays. We do SFIL only.
Yes.
Any other questions or opinion or comment by our chairperson? Gavita, you can go to him.
Am I
Good evening,
audible?
Dr. Sudhir.
Am I
Yes, sir, you are
audible?
audible.
Yes, sir. So both say you are audible.
Actually, thing is that sometimes we put the blame on the type of lens only, but I think some of the complications like endothelial loss and cystoid macular edema or glaucoma could be due to the other factors also. Suppose you haven't managed the vitreous properly, or there is a retained lens matter, or the proper improper technique of the lens implantation, then that can also cause the complications which we try
In
to
fact,
blame on the.
the primary surgery also that is the culprit most of the time.
Yes, yes,
But we
exactly.
blame on the ACL.
So coming back to the techniques, I think uh, not all technique require a vitreoretinal surgeon. Even the anterior segment surgeon can can master some of the techniques very easily. For
True.
example, I think all the cataract surgeons, they should know how to do a good sulcus fixation lens. So because that is very easy, but at the same time, we have to remember that before implant going for a sulcus fixation lens, we always uh, learn the technique of good anterior vitrectomy. That is, I think, more important. And now there is always we have good anterior vitrectomy machines available, automated anterior vitrectomy. So 2 3 points about anterior vitrectomy. I think all the surgeons, all the particularly the resident, they should know the parameters, because
Yeah.
if they don't know the exact parameters like what will be the cut rate and aspiration and irrigation, then it makes the anterior vitrectomy very cumbersome also. So I think 2 3 things. One is always try to do anterior vitrectomy in a closed chamber technique rather than going through the main incision, and also uh, the aim should be traction on the vitreous should be minimal. It should be more cutting. So always you should have a machine which is having high cut rate. So if it is there, and also we should also try to preserve as much as anterior and posterior capsule whatever is there, because if you keep on increasing the size of the PCR, then it makes the IOL placement very difficult. Also, the parameters, we should also know the parameters of the peripheral iridotomy is totally different. Here, the cut rate would be quite low. So that should be all these surgeons should be aware of these kind of things. And also, Dr. Gauri has already mentioned about the power of lens. That should be you should be aware that what power of lens you will be using. It's always better to do optic capture in a sulcus placed lens. That helps not only for the power optimization, but also for the uh, movement of the vitreous and lens also, because the lens is more stable if you do a good optic capture.
Mhm.
So that is there. And next, ACIOL. ACIOL, when we started, we used to do a lot of ACIOLs, but always mixed results. Some of the patients were doing very good. Some of the patients were having a lot of complications. So we realized that it's basically the vitreous management and the retained lens method which was causing more of a problem. And more importantly, as mentioned by Dr. Gauri, is the lens size. But you have to remember 2 things. If you are placing the lens horizontally, always take horizontal white to white. If you are placing it vertically, it should be
Yeah.
vertical white to white. And also be careful that you do the peripheral iridotomy at 90 degree to the
Mhm.
placement. That makes your thing easy. And sometimes we are confused about the orientation of the IOL, which side. So look at the bolt carefully. It should always be anterior because you want to avoid pupillary capture and pupillary block. And thirdly, if you look at the lens and if you try to insert the lens in the same direction, just look at the optic haptic junction. Don't look at the whole haptics. That will create confusion. So optic haptic junction, if you look, and insert is the same manner as you are inserting a PCIOL. So that will help in putting the lens in correct orientation. I think also iris claw lenses, if your iris support is good, then it's a good choice also. It's very difficult to say which one is better. Iris claw lenses, initially we have seen so many cases of iris claw lenses with PBK, mostly due to the fact that those were anterior iris claw lenses, where the movement of the lens used to cause damage to the corneal endothelium. But now the retropupillary lenses are doing better, much better than the anteriorly placed iris claw lenses. Although Dr. Daljit Singh's hospital has come with a new anteriorly fixed lens with 4-point fixation, which they claim that it's a more stable lens, but we don't have much data about it. Posterior retropupillary iris claw lenses, just want to give 2-3 points, two, three tips. One is your side port should be more limble compared to the what side port we make. That makes the inclination more, that makes it easy also. And also, as Dr. Gauri told, that look at the forceps. All the forceps they give you direction, which direction to, where should be the point of inclination. And another thing about the scleral fixed lenses is as a glaucoma surgeon, we are definitely more comfortable with the techniques which preserve as much as conjunctiva as possible. So I was very happy to see Yamane's technique and four flange techniques where they were doing transconjunctival. But my only concern is that how frequently do you encounter hypotony in this kind of approaches?
So it's
Uh,
not very uncommon. Actually, sir, the thing is that there are multiple points from where the wound leak can happen. So, of late, I have started using 24 gauge needle instead of MVR. MVR 25 gauge also we can use. That's not a problem. Because when we use a 24 gauge needle, the sclerotomy is not very big. But with so the wound leak is less. Sometimes whatever post-op hypotony we encounter, majority of it actually goes off by day 5. That is the only thing. So what we actually fear is CDs, and CD then eventually resulting in RD. That is the major fear. So that is the only thing.
One
So
more thing I was wondering about the lens centration in scleral fixed lenses. One is that it should be exactly 180-degree opposite.
yeah.
Secondly, the point of entry into the vitreous exactly the same distance from the limbus. Thirdly, is there any role of the amount of the size of the haptics which you are tucking, if one side more than the other side?
Ideally, it will lead to, if in constricted pupil, it will have no effect because the optic will be there anyway. But if one side is under tugged and the other side is over tugged, over a period of time, the under tugged side can actually have an exteriorization which may lead to subluxation. So ideally, it should be equal on both the sides. But little bit won't make a difference. But it shouldn't be too much on one side and too little on the other side. Then you should give a little time during the surgery and adjust the haptics. When there is very short, when there is very short tuck-in, those haptics tend to exteriorize, like very high myopes, where the corneal diameter is high. So the difference of that 1.5 millimeter from limbus, that distance also gradually the haptics, they become sort of, it's not straight, but very very little part gets tucked in. So I have one such case, and that person eventually had an IOL subluxation, and he was the first patient where I advised iris claw lens.
Well, I think
Retropupil.
I find one of the advantages of scleral fixed lenses that since you are into the vitreous and taking care of any debris or the retained lens matter, so that definitely I think help
Yeah.
Particularly for secondary glaucoma and CME.
Yeah.
And that since I think retina guys are doing so good as a file that we have stopped doing ACIOL and iris claw lenses.
Thank you, sir. But I think all the IOLs, all the techniques, they have their importance even today. Like in peripheral centers, when you go, we are sitting in a metropolitan city, very easy to say SFIOL and with all the fancy things. But when we talk about those very remote areas, yes, ACIOL is a good choice. But definitely, while putting the IOL, we have to take into consideration all the things like sir pointed out, that if you choose the right ACIOL, the risk of corneal decompensation happening is much lower. Matlab, so much I've not myself seen much of ACIOL happening, because yeah, right from the beginning, wherever I was, they had excellent retina backup. So that's why not. But yes, it is true that if your workup is good, you'll not go wrong always. That is something that we have to agree upon.
One of the problem of doing primary ACIOL is the availability of proper size of lens,
Yeah.
and that is a big problem. So
Mhm.
that's why uh, I think the primary ACIOL, the problem happens because the proper sizing is not there.
Yeah.
And how frequently your haptic fractures while doing SFIOL? Is it?
Yes, sir, it happens. It happens not very frequently, maybe one or two in, say, 25, 30 cases. It happens. And those cases, then we have to remember, okay, oh, that person will come. You see. So in those cases, if actually it's a very small part which has fractured, so what I do nowadays is that I'll put a 10-0 nylon and bury the knot. I'll put a 10-0 suture around the haptic, like, around, passing through the sclera, and then I bury the knot, so that, trying my best to secure the haptic in place. And at the same time, the sclerotomy, if I see that the sclerotomy is big, then I put a 10-0 vicryl over there also, just so that, this thing heals up before this haptic goes down.
Another thing
And
is
one
that
more thing that can be done here is, one more thing that I do also, and that can be done if there's a very small tip that is very small part that is fractured. You can always, with the help of cautery, just dithermize the tip like the Yamane, so that, your vicryl will give that time for the wounds to heal. And even if it subluxates a bit later, it will never slip down.
uh, I have seen one video that one of the surgeon, he was passing the needle through the single piece lens optic haptic junction and flanging it.
Yeah, I have heard, but I have not seen. But uh, some people try anchoring in the ciliary sulcus, like how there are like how people suture the IOLs to the iris. Then there are reports of suturing to the ciliary sulcus. However, I have encountered, uh, I mean, it was, I don't know, removing that suture was a pain. So that ciliary area, the suture was there, and I was like, where is this IOL hanging from? I had to do SFIOL. Then indentation to reach that area of indentation where that suture was. I was so scared while doing the vitrectomy that I'll end up eating the ciliary body, and there will be bleed, 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 bleed.
And how far is your point of entry from limbus? It's 2 or 1.5?
1.5 millimeters. So 2 actually is a bit too far. If we make it at 2, the haptics, that much amount of the length gets shortened, because that becomes horizontal length. So 1.5 millimeter straight entry, we can increase the IOP just for that moment while we are entering. Just increase the IOP to 60, because what it does is that because of high IOP, the iris gets shifted up. So otherwise the iris would be hanging down like a bow. So when you'll go down, you'll end up hitting the iris, and then at the same time there can be injury to the iris or to the root of iris. So it has to be a straight entry, one go at high IOP.
So it's always irrigation on while doing all these
Yeah,
things.
yeah, yeah, yeah. Irrigation on. And the instruments should be sharp. Very important. Blunt instruments will not work well. Reuse, reuse, reuse. Yeah. You have to be careful. One very, very important point, yes. So while we are making the tunnels, the MVR that you are given, please check the tip because it's a partial thickness scleral tunnel. So if your MVR due to repeated use, if it is bent tip, while you are making the tunnel, you will not realize that bent tip, if it is facing down, you will actually end up injuring the uveal tissue underneath. And suddenly you will feel that I just made a scleral tunnel. Why is the AC having bleed?
Dr. Garbita, any other question?
Yes, sir, we have a lot of questions. First is which IOL is preferred and which technique is the most preferred
Which
for
I will
SFIL?
in SFIL, which I will. So you can use a PMMA non-foldable three-piece lens. Okay. Or you can use a foldable lens. So depends upon the affordability of the patient. If your patient is very poor, this Apasami three-piece non-foldable lenses come. They are not expensive at all. So you can use that lens. Now the choice is yours, Gabers or XNet, what you want to do. If you are doing, see, if you are doing SFIL at the same time, and if you have already made a spiral tunnel, then okay, then you can do an XNet. But if you have done a phacoemulsification and if you have a foldable three-piece with you, then just go by that only. You can just go by that. No need to do XNet. You can just do Gaber's technique. Also, that fibrin glue adds to the cost. If you have extra fibrin glue lying around your center, or if your patient is willing to pay, add fibrin glue, do a glued IOL along with. But if your patient has no money for glue, if your patient has no money for a foldable IOL, you can just go ahead with either XNet or a Gaber's technique straight away and use the non-foldable PMMA multi-piece. That is entirely, a lot of factors actually are important. It's not like what is the most commonly done. A lot of it also, patient factor also is important. And also what you are good at. And also what the cornea demands. If you have a lot of corneal edema, and the visualization through the cornea to catch a haptic in the pupillary area is very poor, go for XNet. If your visibility is good, then whatever works better in your hands.
Right, ma'am. Thank you, ma'am. Next question is any additional investigations that need to be done before secondary IOL implantation surgery?
Very important, 2-3 things. If first is specular microscopy, IOL power calculation. First thing is check the visual acuity of the patient. Very important. Check the BCVA. Patient should not say that all this, you have done everything and my vision is not improving. Okay. So first check the visual acuity, do a good examination. It should be worth it. It should not happen that the patient has GOA behind and you
Yes.
are doing patient because, and suddenly, whatever little was remaining, you have a wipeout post surgery. Okay. So that should not happen. Then following that, once your physical examination, check the BCVA and what is the status bilaterally. Okay. Always do a specular and your IOL power calculation. Tell the patient if your counts are poor, then always tell the patient that, that there is a problem, that there might be a probable need for a corneal procedure in future, or you may need prolonged medicines for the corneal edema to manage this keratopathy. All that you have to do beforehand.
Right,
You're
ma'am.
answerable. And post-operatively manage the hypotony or the glaucoma, whatever comes your way. Manage vitreous very well.
Next question is, ma'am, between SFIL and iris claw, what is preferable and why?
SFIL, I would say, is preferable any day because with iris claw, there is a long-standing risk of iritis and CME, which doesn't happen with the SFIL usually. Okay. Also, that the risk of glaucoma is much less with SFIL compared to iris claw. Also, that the cases of bullous keratopathy are more with iris claw compared to SFIL. So yes, if you are asking me to prefer one, it's SFIL.
Right, ma'am. Next question is, in a secondary IOL implantation in a traumatized lens, how can we overcome post-op inflammatory marker release related endophthalmitis? What is your preferred regime, ma'am?
Inflammatory marker release is, I mean, one thing is we are talking about TAS or just post-op uveitis, or we are talking about end-off. Now, there are three things in this. It's a very blanket question. Okay. So first thing is that if you are even in slightest doubt, always take a vitreous biopsy. Okay. Before the surgery, if you have some, if there is some time remaining for the surgery, meaning like you're seeing the patient in the morning or the previous day and the surgery is scheduled next day, always start the patient on oral and topical medicines. Okay. So usually if it is an open globe, okay, in a closed globe, the chances of end off happening are very less because it's a closed globe. If it's an open globe, the first thing you do is you do the primary repair first. You're not going in for SFIOL or any kind of IOL in the primary technique, in the primary procedure. So what you're dealing with in the primary procedure is corneoscleral, whatever tear repair, and cataract extraction if that is something that is gotten affected. Okay. So that is what you do in the primary procedure. Then you see whether there during the primary procedure itself, you can give an intravitreal if you are suspecting end off. Definitely at the same time, you can give vancomycin and organic. If it is an organic matter, you can always give a voriconazole also at the same time. Then after once the surgery is done, you have to wait for the eye to heal. Okay, the wounds should be non-leaking. Do a good B scan, gentle B scan. Okay, and see what the status is inside. Okay, and if there are CDs post-operatively, obviously you cannot repeat a vancomycin, voriconazole or Dexa, whatever you want. Okay, then you definitely have to intervene early. But if there are no CDs, then you can wait also for the main wound to heal. And once the main wound is healed and then you can take the patient up for a secondary procedure provided there is no RD behind and there is no end off. But if there is RD and end off, you may have to intervene early.
Right, ma'am. Next question is, ma'am, in one of the videos, why did you perform anterior vitrectomy?
If there is that is the primary thing. Any cataract surgery, if you are doing, and if there is a PCR and there is a vitreous loss, you have to do anterior vitrectomy. Now, certain techniques like XNET, okay? So they say that if you have done a good anterior vitrectomy, even anterior segment surgeons can do the XNET technique. But the only thing that is at risk is that doing a good anterior vitrectomy means the vitreous is not prolapsing, but you don't know how far it is, retropupillary. So while you are, meddling, while you are going in with the needle coming out, everything, yes, the vitreous can migrate to places and traction can occur and you may find breaks later. So I honestly believe that if you are doing any of the SFIL procedures, do a complete vitrectomy, be safe.
Right, ma'am. Last question, ma'am. What is your method of choice for doing secondary IOL?
My method of choice, if the anterior capsule is intact, sulcus. Definitely, hands down, nothing better than that. If the anterior capsule is not intact, then my method of choice is definitely spiral fixated IOL. depending upon whatever I am seeing. If my view is very clear, cataract has already been taken out. Okay, even if it is in the vitreous cavity, doesn't matter. I can still take a phaco-frag. If it is a very soft cataract, I can cut with the cutter. If it's a hard cataract, I can cut with the help of phaco-frag. If it is a very hard cataract which doesn't get cut with the phaco-frag also, after doing complete vitrectomy, I will probably make a spiral tunnel or make an ECCE wound. Either with the help of PFCL, I will make that cataract float, the cataractus part float, or I'll engage it in my MVR and bring it out and bring it in the pupillary plane and then deliver it through the spiral tunnel or the ECC wound. So that is what I will do. And then definitely my SFI will, whichever way. I mean, I usually do the Gabers. Almost 90% of my cases are Gabers technique. Yamanes I don't do. I only take a part of Yamanes where the haptics are falling short. That is the ballpoint cautery. That is what I do in case of high myopes or if by chance the haptic has fractured.
Right, ma'am. Those were all the questions, ma'am. Thank you for the PPT for such a wonderful class that covered all the aspects of such a intricate topic, ma'am.
Thank you so much. Thank you, Garvita. Thank you, Subodh sir.